Thank you very much for that very kind introduction. I'm going to go ahead and share my screen and let's see, share. Today's topic, as you've already been introduced, is changing paradigm of hyperphosphatemia and CKD, role of sucroferric oxyhydroxide. And I'm going to start by describing some of the pathophysiologic underpinning for management of phosphorus, and then I'll spend most of my 40 or so minutes describing the clinical trials evidence that supports the use of this agent as a key element in the management of oral intake of phosphorus and the management of hyperphosphatemia in CKD and end-stage renal disease. I begin by noting that an international consortium of experts in the field have compiled the KDIGO recommendations for mineral and bone disorder. These were from 2019, and these were importantly reflected the knowledge to that point. However, the newer iron-based phosphate binders were only coming into play at that time, so these were not yet fully reflected in these recommendations. Having said that, these recommendations clearly set the goals for the management of phosphorus and the use of non-calcium-based phosphate binders to manage hyperphosphatemia and CKD and ESRD. And that's based on a simplified cartoon here of the pathophysiology of secondary hyperparathyroidism and its consequences in patients with chronic kidney disease. What you can see in the center of this slide is that there is an early signal that increases FGF23 and possibly the FGF regulatory factor Klotho complex that have direct consequences on the normal hormonal modulation of bone and mineral metabolism, both for the bones and for the vasculature and for the response of the parathyroid gland. And this increase in FGF23 that occurs during CKD is predicated on a signal that probably is most likely the increased phosphorus burden that occurs in individuals as their renal function is declining. And this results in a normalization of serum phosphorus level through much of CKD or near normalization. But as CKD advances to near end-stage renal disease and finally dialysis requirements, this ability of the phosphatonins such as FGF23 to maintain a normal serum phosphorus level is overcome and serum phosphorus levels increase, and these signals are all amplified. The net results of these signals is that there is secondary hyperparathyroidism, there is a lack of active vitamin D, and there is a trend to amplify vascular calcification and the cardiovascular consequences of renal failure. And this slide from Miles Wolf's work demonstrates the changes in these key markers of mineral and bone disease and CKD that occur long before we reach the need to implement dialysis in these patients. And so as we think about managing CKD, MBD, we should think about how we manage it most appropriately antecedent to the onset of dialysis, as well as during the dialysis period. And that then brings us to the notion that possibly reducing the phosphorus burden on these patients early on, and certainly when they become hyperphosphatemic, may impact the course of comorbidities that occur during CKD, including cardiovascular comorbidities and even some evidence on the progression of chronic kidney disease to end-stage renal disease. The cardiovascular elements of this are well recognized in clinical medicine, and the mechanisms by which this occur have been studied over the last 2 decades. This is a summary slide from early work by Gia Kelly and her colleagues demonstrating the importance of increased phosphorus and increased calcium on the sodium phosphate cotransporter in epithelial cells that result in a change in the mineral matrix in the vasculature and a change in the expression of these cells to be more osteoclast-like and therefore the blood vessels become more bone-like. And these are all phenomena that our therapies are intended to minimize and to protect our patients in end-stage kidney disease and in chronic kidney disease, so that they do not develop vascular disease and have premature mortality and major morbidities. The kinds of morbidities and consequences of CKD MBD are listed here on this slide. They would include renal osteodystrophy, which is the earliest recognized consequence of this disease. That's hence the bone part of it, which is a consequence of abnormal mineralization and results in pathologic fractures and other serious consequences to our patients. We often don't think about renal osteodystrophy because we're so focused on the third of these, which is cardiovascular calcification and other abnormal calcifications such as extraskeletal calcification. But renal osteodystrophy is a debilitating phenomenon for people with late and severe kidney failure. Late and obviously hyperphosphatemia is the consequence. Hyperphosphatemia slides, and there are other endocrine disturbances, and there are other pathways where these vitamin D products are necessary for endocrine functions, not only in the parathyroid gland, but through multiple tissues. There are neurobehavioral changes that may be related to the abnormal mineral and bone hormonal regulatory pathways, and of course, compromised immune systems. And if you have renal osteodystrophy, you can even see impact on erythropoiesis. So all these phenomenon are the consequences of unregulated and untreated CKD MBD, and do speak to the notion that our management of this is important. So management of hyperphosphatemia and CKD, which is a key element in the initiation of this whole process, includes dietary restrictions and dialysis, but these alone in end-stage renal disease are usually insufficient to control hyperphosphatemia, and therefore oral phosphate binders are frequently prescribed. I'm not showing you the slide of the frequency, but by the first 6 months of patients on dialysis in the US, more than 80% of patients will require phosphate binders to meet the KDIGO goal of phosphorus control. In cross-sectional observational studies with dialysis patients, administration of phosphate binder therapy has been associated with substantial reduced risks in mortality compared with no treatment, and also with reductions in vascular calcification. In particular, if calcium-based phosphate binders are avoided, there is, in comparison to non-calcium-based phosphate binders, calcium-based phosphate binders are associated with an increased risk of hypercalcemia and vascular calcification. And this has led to the development of multiple different non-calcium-based phosphate binders over the last 2+ decades. So these are the various phosphate binders listed on the right-hand side, some of which are calcium and some of which are non-calcium-based phosphate binders. And I'll have multiple additional slides summarizing some of the findings in these particular binders. An ideal binder, as listed on the left-hand side of the slide, would be something that binds phosphorus in the digestive tract, is minimally absorptive, causes no vascular or cardiac complication, has a high and specific affinity for phosphorus alone and not for other important elements, has a high binding capacity, is non-toxic, and importantly, very well tolerated, and reduce the risk if it can be demonstrated of mortality and comorbidities, and could be easy to administer with a low pill burden. And if one can minimize the pill burden as much as possible, that will often translate into very much improved adherence with the medication. And we'll show you some data from a 2-year longitudinal cohort Fresenius trial by Coyne and colleagues on adherence to the medication because of the reduced pill burden with Sucroferric Oxyhydroxide, as well as the European Verified trial that has also measured that. So there are limitations for currently available phosphate binders. If I start with the ones in the middle, I've already alluded numerous times to the potential impact of calcium-based phosphate binders, whether it's calcium acetate or calcium carbonate, on the risk of hypercalcemia and associated progression of cardiovascular disease. And I was involved actually in a randomized controlled clinical trial which demonstrated that in end-stage kidney disease patients in Italy. Aluminum salts have been used for at least 4 decades as a phosphate binder, but there is ample evidence from epidemiologic studies of potential for toxicities, including encephalopathy and anemia as a consequence of the accumulation of aluminum and aluminum toxicities, which remain in the epidemiologic literature a real and important phenomenon. And then there are two, before we get to the iron-based phosphate binders, there are two other non-calcium-based phosphate binders that are currently used around the world, the sevelamer-based binders and the and lanthanum as a binder. I will make some comments about sevelamer in comparison to sucroferric oxyhydroxide in subsequent slides where those comparisons are made. Because it is generally one of the most commonly used non-calcium-based phosphate binder around the world. So let's talk about the sucroferric oxyhydroxide in a non-calcium iron-based phosphate binder, what it does, what it looks like, and how it compares to the other phosphate binders, including the other iron-based phosphate binders. So on the left-hand side of the slide, you see a cartoon of the molecular structure of the binding element, the oxyhydroxide core, which is where the ingested phosphorus is bound, and then it is shielded from from being consumed by binding other things by the starch and sucrose covering. So sucroferric oxyhydroxide comprises this polynuclear iron oxyhydroxide core, which is stabilized with this carbohydrate shell. The carbohydrate shell is used to preserve the capacity of this core to bind phosphorus. The good news about this particular structure and arrangement is that it operates along the entire GI tract. And with a pretty stable capacity to bind phosphorus in GI tract pHs of 1.2 to 7.5 where it has been measured. And maybe even beyond that, but those are really the physiologic parameters that are useful for our patients. In an aqueous environment, the GI tract, the phosphate binding takes place by liquid exchange between the hydroxyl groups and or water with the sucroferric oxyhydroxide and the phosphorus in the diet. Now, I'll read you a little bit about the typical dosing, and then I will show you some comparison with the binding capacities with other phosphate binders that are currently available for our patients. So the recommended starting dose is 500 milligrams of sucroferric oxide 3 times daily with meals, and this is the typical dose that has been utilized. That would be 3 tablets per day. So serum phosphorus levels should be monitored, and the dose is titrated up or down in increments of 500 milligrams total change per day every 2 to 4 weeks until an acceptable serum phosphorus level is obtained. And in most of these slides, we're going to use that acceptable level using the units that we use here in the US, and I believe you also use in India, 5.5 milligrams per deciliter. Some of the slides have the European millimoles on them, so I'll point that out. This is the KDIGO recommended target for patients with end-stage kidney disease on dialysis. In clinical practice, treatment is really based on the need to control serum phosphorus levels, and most patients respond quite well with 3 tablets per day. In the longitudinal follow-up studies of 6 months, 1 year, and 2 years from Coyne and his colleagues, the average dose of sucroferric oxyhydroxide was approximately 4 tablets per day. So the maximum recommended dose for the clinical trials was 6 tablets per day. And should be noted that there's no metallic taste. The tablet should be broken. It doesn't have to be chewed to a pulp. It just needs to be broken so that the agents are available now to the digestive juices so that when it gets into the stomach, it can start to act. And then it's swallowed as a chewed tablet. It does not, again, have to be chewed to a pulp, and it could even be cut or crushed prior to ingestion if that were something that a patient found more palatable. I have actually tasted this product, and I should note that it does not truly have an metallic taste to it. Now, this is a analysis that Dr. Gut-Kunst reported on a few years ago, comparing the binding capacity of various phosphate binders, both the calcium-based and the non-calcium-based phosphate binders, the 3 calcium-based phosphate binders on the top, and the subsequent non-calcium-based phosphate binders on the bottom. All normalized to a 1 gram equivalent 1 gram dose of calcium carbonate. The calcium carbonate, which is listed on top, has a phosphate binding capacity of 0.75. That's because the tablet is 750 milligrams. And you can see calcium acetate has a slightly lower binding capacity, albeit also a little bit lower calcium load according to balanced studies. Lanthanum is at 1, cevimelir carbonate, an 800 milligram tablet, cevimelir hydroxychloride is also, HCl is also the same, 800 milligrams is 0.6, and ferric citrate on the bottom is 0.64 per tablet. The sucroferric oxyhydroxide in the US and Europe is Valporo. In India, it will be the product you're learning about tonight. Binds, the 500 milligram tablet binds 1.6 times as much as 1 gram of calcium carbonate. And if you look over to the next to the last column, you can see that on average, to achieve a binding of about 6 grams per day of phosphorus that you might find in a typical high protein based diet, that calcium carbonate and acetate require 8 to 9 tablets. Cevimelir carbonate would require 10 tablets per day, and sucroferric oxyhydroxide comes in at just under 4, the kind of level that is seen in most of the advanced clinical trials. So let's look at the clinical trial studies. I'm going to start with the one of the registry studies by Flüge and his colleagues that looked at the efficacy and side effects of sucroferric oxyhydroxide compared to equivalent doses of cevimelir carbonate, equivalent in the sense that they were dosed to achieve a serum phosphorus target. So this is a randomized controlled clinical trial that was used to identify and describe this medication in the early stages. And this is the trial design. So there were initial run-in period of 24 weeks patients who were either given sucroferric oxyhydroxide or cevimelir carbonate. At 24 weeks, there was a small group who were reduced from the intended therapeutic level of sucroferric oxyhydroxide to a low dose. These were then ultimately withdrawn after a 3-week period of time. And this demonstrated that in these patients, those who were managed with the sucroferric oxyhydroxide, that when they were withdrawn, the well-achieved phosphorus levels that were observed in the first 24 weeks were obliterated when they went back to their non-phosphate binder treatment. And then the trial was extended with a small group of crossover patients, no crossover patients, but extended for cevimelir carbonate and for sucroferric oxyhydroxide. The medium, large, and higher group were added to that, and this was extended up to a year plus a 3-week washout period. So 52 weeks of therapy and 3 weeks post. And these are the data from that trial. On the left-hand side, you can see that with both the sucroferric oxyhydroxide and cevimelir carbonate, that they achieved the target reduction in the serum phosphorus level, such that one could say that any changes that one saw in the trial were not due to inadequate treatment with one arm or the other. And then what you see in the middle is that there was achievement of the KDIGO upper limit of phosphorus. This is a mean, so there were some patients that did not achieve this, and we will look at a post hoc analysis of this study to determine what characteristics might have identified prior to treatment those who might be more resistant to the effects of phosphate binders and to the effective reduction in serum phosphorus level. And then on the far right, you can see the mean number of tablets that were used in this trial. And what you can see is that initially there were 3 tablets for the common dose for the SO group, and sevelamer carbonate was 8 tablets. During the mid-phase of the trial, it was 4 to 10, as one would have predicted from the Goodkunst analysis. And then at the conclusion of the trial, it was 3.3 and 8.7 as the patients were transitioned off the trial observation period. So it persisted, this lower pill burden persisted. They also looked at some important side effects, potential side effects, and this will also be evaluated in the VERIFY trial that was conducted in the EU, specifically to look for side effects such as iron accumulation and other consequences that theoretically might occur with these two treatments. And what you can see here is that neither with the SO or with the sevelamer was there any iron accumulation during the time of this 52-week trial. So this is a phase 3 trial, so it was a randomized controlled clinical trial for understanding both the treatment and emergent adverse events. Treatment-related emergent adverse effects were more frequent with SO compared with sevelamer carbonate. I'm going to show you that in just a minute. The majority of these were mild transient diarrhea. Discolored feces were also seen, as one might expect with an iron product. Constipation and nausea were more frequently with the sevelamer carbonate arm. The safety profile for sucroferric oxyhydroxide was similar in the groups of patients studied, and all cause of discolored feces with sucroferric oxide occurred during the phase 3 transition phase, titration phase, so early on in the trial, and none led to withdrawal. Diarrhea was generally very mild and did not require withdrawal from treatment as well. Now, I did say I was going to show you those data, but I'll show you the data on the VERIFY trial that look at diarrhea as well, which I think is just as illustrated. But this is a post hoc analysis of this particular trial that was published some years later by Kovic and colleagues, and demonstrates that there was a difference that you could observe in the patients who achieved phosphorus control versus those who did not. One difference was that those who did not achieve the control measures, which in this case was at a serum phosphorus level of less than 5.5, had a higher starting serum phosphorus level. And you would say, well, maybe that's just because they had a longer way to go. But if you look at the line just below that, the reduction in serum phosphorus level was much more prominent and greater in those who achieved control, and really not very substantial in those who did not achieve control. And this was also observed to be predicted by being somewhat younger in age and having a higher BMI, and maybe the higher starting serum phosphorus level did indicate a trend towards being less adherent with the medication. That was not reported in this post hoc analysis. So let's look at the real world experience, because I think these will be instructive. This real world experience, this is I'm going to show you this 6-month analysis and then the 2-year analysis. There was both a 1-year and a 2-year analysis, which very largely reiterate what was shown in the 6-month analysis. And these are data that are drawn from a large dialysis provider's electronic medical record and their pharmacy system, the Fresenius dialysis system in the US, which dialyzes about 50% of our dialysis patients here in the US. And they have a mail order pharmacy. And so one was able to exploit this pharmacy information to look at how well sucroferric oxyhydroxide fared in this real world population. So I'm going to read the conclusions and I'm going to show you a little bit of the data. The sucroferric oxyhydroxide demonstrated controlled serum phosphorus levels with a low mean prescribed number of pills. I should say that these changes to SO were determined and driven by the clinicians, and the patients who were largely recruited to this cohort, so to speak, were those who had a poor control on antecedent use of phosphate binders. The proportion of patients with serum phosphorus level of less than 5.5 increased from a measly 15.6% at baseline to 30.4% at 6 months. And it was well received at 3 months and 6 months. So let me just show you some additional data. These are just the data showing the comparison between the achievement of phosphorus levels and the pill burdens that were antecedent to the change from another phosphate binder, in this case, Velamir calcium acetate and lanthanum carbonate. In each case, the achievement for all phosphate binders and or each individual phosphate binders was less than 15%. And then at 3 months and 6 months, it achieved up to 30% success. And what you can see on the right-hand side, the number of pills was reduced from an average of around 8.8, to about 3 to 4 pills per day during this observational period. Now, in discussions subsequent, and I was party to this discussion, we thought that it would be really good to look at a more long-term evaluation. And this study was designed to really try to match something that might be akin to propensity scored analysis of a observational epidemiologic study. In this case, everyone in this trial, or this observational cohort, was prescribed, switched from a phosphate binder largely, and then prescribed SO. And then after a period of somewhere between 30 and 90 days, there was a proportion of these individuals who were switched to the non-SO phosphate binder therapy, either because they achieved control with the Sucroferric Oxyhydroxide, or they were intolerant, or they just couldn't afford it, or some other reason. So the reasons for the switch were not specified, but it was not simply because of intolerance, but there were often just choices in terms of preference of patients. And what you can see is that then these patients were either followed in the non-SO group for up to 2 years, versus those who were maintained on the Superferric Oxyhydroxide therapy for a full 2-year period. And these are the results by quarter of the achievement of phosphorus control. What you can see clearly is that phosphorus control was inadequate antecedent to the initiation of the SO. And then what happened is that the patients who were on SO and switched back in the brown bars here achieved a little bit better, because now they were in clinical observation, but did not maintain as good an outcome as that observed in the similar type patients who selected to continue with the SO therapy, where the achievement of the goal of serum phosphorus level of less than 5.5 was achieved and this is the way this was measured, was achieved in excess of 40% of patients. And this success with control of phosphorus was continued through a full 2-year period. What you can also see on the bottom is the serum phosphorus levels of the two groups. It was the mean was at the end of the trial was 5.98 for the SO group, and the non-SO group it was back up to 6.34. So there was some control in some, and there was a substantial difference in the number of phosphate binders that they were prescribed and were taken in this real-world experience. Again, this is real-world experience. These are not selected for a clinical trial. These are our average type of patient. I also choose to show you these because these are the real data, and clearly what you can see is that the SO group achieved a higher level of phosphorus control, as I've already indicated. There was no difference in the serum calcium levels in the group, and in this observational study, there was really no impact, significant difference in impact on the PTH, intact PTH, albeit it seemed to trend in the same direction with both. The other safety measure that is always of concern was what happened to the hemoglobin and the iron studies. On the bottom, you can see that in this, again, real-world experience, There was no change observed in the serum ferritin levels. The ferritin levels started pretty high to start with, but they did not change. There was a very mild change in the transparent TSAT, transparent saturation, but not clinically significant. It is statistically significant in this very large trial, and the hemoglobin levels did not change significantly. Now, the verified trial from Europe will look at these same parameters again. And the interesting thing in this is they also looked at the hospitalization rates, and for reasons that have not been explained, those who were continued on the SO versus those who were switched to other phosphate binders. And remember, both groups were being maintained on phosphate binders to achieve an adequate control of phosphorus, albeit there was better control of phosphorus in those who were maintained on sucroferric oxyhydroxide. And I should also note that these were limited to monotherapy patients only, so there were not any crossovers or dual therapies. And what you can see is that there was a reduction using multivariate models to account for differences in diabetes status and smoking and other factors that might influence cardiovascular and other forms of hospitalizations, that there was a reduction in long-term hospitalizations and in all hospitalizations in the multivariate model. The importance of a greater than 24-hour hospital stay is that some people might be hospitalized for very transient vascular access repair or something like that, which is often less than 24 hours. And this is just summarized what I just said, so I'm going to switch that as continue in the interest of time. I've left this next slide in. This is a small study that was also observational, but I want to, and they found basically the same kinds of findings as I've just reported to you from the previous 2-year observational study that was much larger in the US. This is in Europe, of course. And but I do want to point out to the last 2 bullets here that they observed a improvement in the cholesterol level and in the lipid profile. And there are other reports, both from epidemiologic studies and from some of the clinical trials, that demonstrate some improvement in lipid profiles that may be observed in patients treated with SO, albeit this has not been fully characterized. The other thing that is of interest is that the albumin levels remain very stable. I didn't show you an observational study in peritoneal dialysis patients, but in peritoneal dialysis patients, albumin is more difficult to maintain because of the losses of protein sometimes in the PD fluid, and nutritional status in these patients is very critical. And what Dr. Ken Kalantar-Zayde demonstrated in the trial, that in the PD patient population, albumin levels actually improved with superferric oxyhydroxide, and this would support the notion that this agent does not interfere with important nutritional goals and the absorption of proteins and other nutritional agents. Again, I'm going to skip that. So I want to turn to the VERIFY trial and then one other trial and end with that. So this is another real-world trial. It's a non-interventional prospective multi-center cohort study conducted in 7 European countries, principally to evaluate the safety and effectiveness of sucroferric oxyhydroxide in dialysis patients with hyperphosphatemia in routine practice. The safety outcomes included adverse drug reactions and changes in iron-related parameters, and the SFOH effectiveness was evaluated by changes from baseline in serum phosphorus and percentage of patients achieving target levels. And these will be using European units. This was the design of the study. There was the actual prospective trial was a 6-month free trial, retrospective analysis, and then a 36-month period. In the second phase, there were patients who were already in an observation period, but not as part of this trial, that were then included so that they had 42 months on sucroferric oxyhydroxide. And these are the results. What you can see is across the top that there was achievement of a improvement in serum phosphorus levels down to an average of about 5.3. And the little bar on the bottom is the percent change from baseline. So these were patients who were not as severely abnormal in their serum phosphorus levels as the prior trials that I demonstrated to you, but did achieve the target control with this agent. What you can also see is that the proportion of individuals who achieved either, I said these were in European units, but actually these are the North American units, serum phosphorus levels of less than 5.5, the dark blue bars, or even better yet, serum phosphorus levels of less than 4.5, were substantially increased in the subjects that were treated with sucroferric oxyhydroxide, and this was sustained over the full observation of the trial. Now, diarrhea is really the most commonly reported adverse event. On the left-hand side, you can see the frequency of either missing data, which is light blue, or severe, which is what we should focus on, moderate or mild. In the first column, which is the first month, that's expanded, and you can see that most of the events occurred in the first week, and most of them were mild or moderate, and there were very few severe, and that the reported episodes of patients who were maintained on this agent was substantially reduced as the weeks went ahead. And what you can see is the majority of patients reporting their first episode of diarrhea lasted less than 1 week or 1 to 2 weeks, and very few of them were persistent or long in duration. So this is a common side effect. It does cause some looser stools that are sometimes classified as mild diarrhea. They were careful to try to make the definition correct, but some patients continue to think looser stools are a diarrhea. Nonetheless, there were no patients that were withdrawn from this agent on the basis of the observed changes in stool habits. This is now the iron parameters, and what you can see here again is that the serum ferritin on top, the TSAT in the middle, and the hemoglobin levels on the lower end did not change throughout the entire period of observation from baseline through the last clinic visit, and I will not belabor those. This is a measure of adherence in the full cohort of 1,322 individuals, and what you can see is that adherence with this agent by pill counts and by the survey method that's described here in this paper was either very good or very adherent, adherent or very adherent, pink and blue bars, in over 70% of the patients. If you recall your own experience with phosphate binders in your patients, this is a pretty extraordinary adherence to treatment that they are, on average, taking with every meal. So it's not a once-a-day treatment, but it's with each meal. This Spanish trial is much smaller. It's a similar type of design. I'm going to just show you it because it, again, shows very similar type of results. And here again, you can see that from baseline to final observation in this observational study, there was excellent achievement of phosphoruses of less than 5, in this case, milligrams per deciliter, in over 75% or 45% increase from their baseline observation. And adherence also increased substantially to greater than 50% in this clinical prospective cohort observational trial. Now, this is a very complicated slide, and in the interest of time, I'm not going to read it in great detail. I do want to call your attention to this review by Stuart Sprague and Jürgen Flöge from Expert Opinions in Pharmacotherapy, just again outlining all the different binders. And what you can see is that the potential advantages with sucroferric oxyhydroxide that they have listed is: 1, no calcium exposure, low pill burden, binds strongly to phosphorus over a wide, or phosphate over a wide pH range, low iron release and absorption, and no effect on viability of vitamin D antagonists. And most medications, albeit it is recommended that some medications be taken independent and in time-wise from this agent. There are the GI side effects that I alluded to. You can look at the others. Again, in the interest of time, I'm going to move on. And I'm just going to summarize and then open it up for questions. So sucroferric oxyhydroxide has several beneficial attributes that differentiate it from other phosphate binders with respect to treatment efficacy, safety and tolerability, pill burden, and convenience of administration. In terms of efficacy, SFO displays a high phosphate binding capacity, resulting in effective serum phosphorus control with a relatively low pill burden. SFO has a favorable safety profile that is mostly well tolerated, allowing patients to remain on treatment and achieving long-term serum phosphorus. I did note that it causes loose stools or diarrhea in comparison on that previous chart to sevelamer, which is more likely, and in the clinical trials, is more likely to cause constipation. Sometimes patients would prefer to have a little bit of loose stools rather than constipation. That's patient preference. Minimal iron absorption, no evidence of iron accumulation, and I believe that this is a powerful advantage to this agent because you can separately manage iron from this management of phosphorus. And if your iron is at target levels, you don't want to have to switch to another phosphate binder. In this case, you wouldn't have to because there's no real iron absorption. And it's effective in maintaining controlled serum phosphorus levels with a significantly lower pill burden, leading to better treatment adherence than with other agents, including sevelamer carbonate. And with that, I will thank you for your kind attention and open it up to questions in the chat.